No. Okay.
So just by way of introduction, thank you. Welcome to Journal Club, everybody. If I could kindly ask all the sites and all the participants remotely to mute their microphones during the presentation, that would be appreciated. I'm proud to introduce Dr. Christina Reppas-Rindlisbacher, a PGY4 resident with a promising career in clinical epidemiology, investigating delirium. I believe this is her first Journal Club presentation and will be talking to us about the importance of nutrition in hospitalized older adults. So I'll give it to you for a long presentation. So you'll be...
Thank you, Dr. Gandel, for that kind introduction. We're just going to change something here.
The small.
Okay, yeah, that's fine. Okay, so thank you, everyone. I'm going to be presenting some background on individual nutritional support in medical inpatients with a focus on the EFFORT trial, which was a trial published in Lancet earlier this year. And that acronym stands for the effect of early nutritional support on frailty, functional outcomes, and recovery. Sorry, I'm touching this. Is this how I go ahead, or that's not working?
You know what? I think you have space.
Sorry.
Maybe you have to click on this and then.
Okay. Okay, so I have no conflicts of interest to declare. So my objectives today are to review the evidence for nutritional support during hospital stays for medical inpatients. Then we're going to move on to critically appraise the selected study. And then the plan is to facilitate a discussion about this study's implications together. So first, I'd like us all to consider a clinical case. I'd like you to think about Mrs. S, who is an 87-year-old female with a pre-admission clinical frailty score of 5 out of 9. So she's mildly frail. She's from home alone with family support, and she presents to the hospital with a fall, and she's found to have pneumonia and an AKI. Now, geriatrics is asked to see the patient for delirium, which is slowly resolving, but she's not making the expected functional gains. And the medical team notes she isn't eating much and wonders if this is hindering her recovery. So the question is posed, would she benefit from oral nutritional supplements, protein fortification, or perhaps even an NG tube for enteral feeding to help her reach her functional goals? I'd like you to think about this as we go through talking about the evidence in this trial. A bit of background on malnutrition. This is a major public health problem. It affects more than 30% of hospitalized patients, and it leads to muscle wasting and a progressive deterioration of metabolic and functional status. It's associated with bad outcomes like mortality, morbidity, long hospital stays, and increased costs. And it's multifactorial in hospital. The theory is that there's a catabolic state from acute illness that can lead to decreased appetite, and I'm sure we've all experienced this when we've been sick. But there are also particular factors in older adults that make malnutrition even more of an issue, like immobility, being unable to reach the food, environmental barriers like not being able to see the food in front of the patient, or perhaps not being able to open any of the packages. So it's a multifactorial issue in hospital, but particularly relevant to older adults. So the current guidelines right now out of Europe and the US recommend both screening for and offering oral nutritional supplementation to all hospitalized older persons. But these recommendations are actually largely based on pathophysiologic theory and observational data, and not good high quality RCTs. And in fact, they are directly conflicting with recent meta-analyses in this area, including one from JAMA in 2016. This just looked at medical inpatients, 22 RCTs, over 3,000 patients, and interventions included counseling, oral, and enteral feeding. Intervention groups did have a significant increase in weight and caloric and protein intake, but there were no differences with respect to outcomes like mortality, infections, functional outcomes, and length of hospital stay. And then there was a follow-up meta-analysis or Cochrane review in 2017. This also included patients from surgical and ICU settings, so not just medical inpatients. So this was a larger inclusion of randomized controlled trials, over 200 with over 28,000 participants. And their conclusion was that there was very low quality evidence for an increase in weight with nutritional support, but that was essentially it. There was no differences in other short or long-term mortality or short-term serious adverse events. And the issue with both of these meta-analyses is that the trials were very heterogeneous. Most of them were small. I did want to highlight 3 trials that showed some benefit in older adults. This is a population that obviously we're interested in. So there was a small study. This was out of Scotland. Patients were admitted to an acute care of the elderly unit and treated with 120 mils of oral protein by sit feed 3 times a day. And they found some decreased weight loss and mortality in the subset of most poorly nourished patients. Another very small study where the mean age was 70 that also showed that individualized nutritional support showed less complications, improved function, and less readmissions. And finally, the biggest study in older adults in 652 hospitalized patients. This was the Nourish trial. So it was just older adults 65 plus, and this was oral protein supplements versus placebo, and they found an improved 90-day mortality with a number needed to treat of 20, as well as improved nutritional status. So, however, this is conflicting with some of the literature we have from the critical care setting, and I did want to highlight this because this is one of the reasons why there's some uncertainty in this area. There's very high quality, like large high quality trials in the critical care setting that have shown some negative effects of early or full enteral nutrition. So there was a trial in the New England Journal of Medicine in 2011, early versus late for enteral nutrition in critically ill patients, as well as 2 high quality large RCTs, the EMPANEC and EDEN trials. And essentially the bottom line is that there were better outcomes in those that received late or insufficient enteral nutrition. They also had early live discharge from the ICU, and they had fewer complications if they received later or insufficient nutrition. So this led to a recommendation from 2014 published in the New England Journal of Medicine that essentially recommends allowing hypocaloric enteral feeding in the acute phase of illness for up to 7 days. This is in previously well-nourished patients. And this comes back to this theory of autophagy, which means sort of our body's natural responses of clearing the badness that comes from acute illness. And the theory is that if you are feeding someone early, you may be suppressing this natural protection against acute illness. Okay, so the bottom line is that there's a scarcity of high quality data for medical inpatients, and there are conflicts between the current recommendations and the recent meta-analyses. And then we also have critical care literature that shows potential harms. So it's unclear whether screening for malnutrition or introducing nutritional support actually has positive effects on clinical outcomes. And that's where this trial comes in. So this was published in April of 2019, earlier this year, in the Lancet. It's a large randomized control trial, individualized nutritional support in medical inpatients, and we will go into this trial right now. So the objective of this trial was to test the hypothesis that protocol-guided individualized nutritional support to reach protein and caloric goals reduces the risk of adverse clinical outcomes in medical inpatients. This was an open-label, non-blinded, multi-center RCT in Switzerland, 8 Swiss hospitals. They used a validated screening tool for malnutrition. That includes things like nutritional status, using weight loss, BMI, food intake, disease severity, and then there's an extra point added if your age is greater than 70. This is a score that goes from 0 to 7. And then patients were randomized to either the intervention group, which was individualized nutritional support, or the control group, which was standard hospital food. Inclusion criteria were all patients, all adult patients admitted to the CTU over the age of 18. They had to have an NRS score of greater than 3, which puts them at nutritional risk. They needed to be expected to stay in hospital for more than 4 days and enrolled within 48 hours of admission. So this is getting to that early nutritional support point. They were excluded if they were initially admitted to ICU or surgery, unable to ingest oral nutrition, if they're already receiving nutritional support, if they had a terminal condition, or if they were admitted due to anorexia, acute pancreatitis, liver failure, cystic fibrosis, stem cell transplant, or if they were post-gastric bypass surgery. So in the intervention group, this individualized nutritional support was initiated as soon as possible. The goals and plans were defined by a trained registered dietitian. Daily caloric and protein intake was recorded. And then at discharge, all patients received dietary counseling, and if indicated, they were given a prescription for oral nutritional supplements. Oh, there's the control group. Okay, I'll just go over the nutritional algorithm first, then I'll talk about the control group. So the nutritional algorithm included 3 levels. In the first level, it was just oral nutrition. So they had things like meals adapted to preferences, food fortification, snacks between meals, and oral nutritional supplements. These are things like Ensure or Boost. And then they also gave patients multivitamins and multimineral supplements. Then this level was reassessed every 24 to 48 hours. And if patients were not meeting greater than 75% of their caloric and protein goals, then after 5 days, they were escalated to level 2. Level 2 included enteral nutrition through an NG tube, plus the oral nutrition from level 1. And then this was reassessed. And if they weren't meeting greater than 75% of their goals, then they were escalated to level 3, which was parenteral nutrition. However, they were still given the enteral and oral nutrition to avoid villus atrophy. In the control group, they just got standard hospital food, and this was just according to their ability and desire to eat. There was no nutritional consultation and no recommendation for additional nutritional support. However, on discharge, the decision to prescribe nutritional support was at the discretion of the team. The primary composite outcome included any adverse clinical outcome within 30 days. That's how they defined it. And they included all-cause mortality, admission to the ICU, non-elective hospital readmission, any major complications, and a decline in functional status of 10% or more from admission to day 30 when they followed these patients. And this was measured by the Barthel's Index ADLs. Secondary outcomes were each individual component of the primary endpoint, as well as daily protein and caloric intake based on the food records, total length of hospital stay, and short-term change in body weight. They did also look at safety endpoints, including GI side effects, complications due to tube feeding, liver or gallbladder dysfunction, hyperglycemia, and refeeding. So they screened over 5,000 patients over a period of 4 years. And ultimately, they were able to randomly assign 2,000 patients to either the intervention group or the control group. So 1,000 in the intervention group and, 1,015 in the intervention, 1,038 in the control. And then you can see here, we'll go into this later, but some patients withdrew consent. 0 were lost to follow-up. There were patients who died, and all the patients completed the interview who did not withdraw consent, who did not die. So looking at table 1, essentially there are no significant differences in baseline characteristics. The mean age was 72 years, which is probably pretty similar to our CTU population. The mean BMI was 24.8. And most of these patients had an NRS score of either 4 or 5. So they were certainly the moderate sort of nutritional risk. In the admission diagnoses, there were also no significant differences. But I just wanted to highlight here that, so the top 3 admission diagnoses were infection, cancer, and cardiovascular disease. I actually thought cancer that's pretty high compared to our population. And then failure to thrive, which we all don't like that diagnosis, but I just highlighted that because I wondered if those patients were more frail. And so there were about 10% of those patients included. And then if you look at the comorbidities, it's all the typical comorbidities that we would see, but interestingly, very few patients with dementia, only 4%. Look at the very bottom. There's pretty high protocol adherence in the intervention group. Caloric and protein goals were met in greater than 75% of patients. And in the control group, about 50% of patients met their goals. This is essentially saying the same thing that I just said, but it just shows over a period of 10 days, the patients who were meeting their goals. So the control group is blue, the intervention group is red, and you can see that patients very quickly met their goals in the intervention group and maintained over a period of 10 days. Interestingly, despite their various levels of nutritional protocol, very few patients actually got enteral or parenteral nutrition. So most patients actually in the intervention group got the oral supplements. So you can see here, this was just pulled from the supplementary appendix. So 90% of patients in the intervention group got oral supplements compared to only 11% in the control group. But the differences in enteral and parenteral nutrition are essentially there are no differences. I mean, they're very similar. Only 8 patients out of over 1,000 got enteral nutrition, and only 12 got parenteral nutrition. And then there were many more patients, so 25% of patients in the intervention group did get a discharge order for oral nutritional supplements, compared to only 2% in the control. So the results. So there was a significant decrease in the adverse outcome within 30 days in the intervention group. 232 patients compared to 272 in the control group, with an odds ratio of 0.79. Then this was actually largely driven by all-cause mortality and a decline in functional status. So there was an overall significant decreased risk of all-cause mortality in the intervention group, 73 compared to 100 patients. There were no significant differences in admission to ICU, readmissions, or any major complications, but there was a difference in decline in functional status of greater than 10% at 30 days. 35, that's just the numbers there. There was a intervention group had less decline. And then for the additional secondary outcomes, there's no difference in length of stay, but there was an improvement in quality of life scores in the intervention group. So there were no significant differences in side effects from nutritional support. And now we'll go into the critical appraisal. So firstly, are the results of this trial valid? So was the assignment of patients to treatments randomized? So yes, it was randomized, and it was done by a central computerized system. So randomization was concealed. Patients were stratified according to site and the severity of malnutrition. Were the groups similar at the start of the trial? I'd say yes. If we looked at table 1 earlier, the baseline characteristics were similar. The only differences I could find if I dug into the supplementary appendix was that there was a slight significant difference in lung and GI admission diagnoses, but that was it. And then were the groups treated equally is the other question to ask. So outcomes were followed in the same way. But this comes down to the issue of blinding, because presumably the intervention groups didn't receive any additional treatments. But it's actually not specifically stated if they got more tests or more investigations, or if they were, treated differently. It's unclear if this information was collected. And it's always possible that the intervention group got more attention somehow because the clinicians were not blinded. So I would say unclear if the groups were treated equally. And then what about the analysis? Were all patients accounted for? So I'd say yes. So first of all, this was an intention to treat analysis. So all groups were analyzed, or all patients were analyzed in the groups that they were randomized to. And there were 0 patients lost to follow-up, which is excellent. There were some patients that withdrew consent, and they didn't explain why those patients withdrew consent. And then finally, blinding. So as I said before, the participants and investigators were not blinded, so they knew which group assignment they were in. However, the outcomes assessment was done by masked nurses. So, I mean, mortality is a hard outcome, obviously. The 30-day outcomes being like a call over the phone, that was more objective. However, some of the outcomes that were assessed during hospital stay might have been vulnerable to observer bias if the nurses somehow were able to observe that the patients were either in the intervention or control group. And then what are the results? So how large was this treatment effect? So the number needed to treat was 25 to prevent 1 adverse clinical outcome and 37 to prevent 1 death. And this is similar to that Nourish trial that I spoke about earlier, where the number needed to treat was 20 to prevent 1 death. And there were no significant differences in potential harms or side effects. So we don't have to worry about the number needed to harm here. I'd say that's pretty good. And then how precise was the estimate of the treatment effects? This is where we looked at the confidence intervals. So I'd say in the primary composite endpoint, the confidence interval is narrow, and in the mortality, but for mortality, it was a bit more wide, but it was still significant. Okay, so are these patients similar to our patients? I'd say yes. The mean age was 72. 50% of patients were greater than the age of 75. And then this is just a subgroup analysis where you can see that patients greater than 75 did have nutritional support reducing adverse outcomes. I would also say that these admission diagnoses and comorbidities are similar to our patients. However, there's very few patients with dementia, which is a population we see and care about. So I would say in that sense, it doesn't help us in that population. But this was just a study that looked at the admission diagnoses in Toronto by Amol Verma. And I just wanted to put this up here to show that a lot of the common diagnoses are similar compared to the CTU diagnoses in Switzerland. Okay, so is the treatment feasible? So we're not routinely screening for malnutrition. And based on a recent study in 18 Canadian hospitals, dietitians are only seeing about 23% of malnourished patients. So I would say currently we probably don't have the resources to do this. Do the potential benefits outweigh the potential harms? I'd say yes, as the study didn't identify any harms. However, it didn't report on cost effectiveness, but they are planning a future analysis. And then were all patient important outcomes considered? I would say almost yes. So they reported quality of life measures, mortality and readmissions. These are important to patients. They didn't say anything about discharge location, just something that's pretty important to patients. Okay, so in summary, I'd say the strengths of this trial is that it was large, it was pragmatic, it's generalizable, and there was no commercial funding. It was investigator initiated. It was a heterogeneous population of typical medical inpatients with multiple comorbidities. And they used a variety of nutritional support strategies, which was good, although most of them were more getting the oral nutritional support strategies, not the enteral feeding. There was high adherence to the nutritional protocol, and then beneficial effects were comparable across the subgroups, which I didn't present that entire analysis, but that was the case. And it was actually more pronounced in CKD, which is known to predispose to protein and energy wasting, which makes sense. Limitations, so it wasn't blinded, and I would say this may have had an impact on the outcome assessment, especially the outcomes during hospitalization. There could have also been a hidden intervention where maybe patients in the intervention group were more likely to be given assistance with feeding. That was a question I had that they didn't really comment on at all. 20% of intervention group didn't meet goals, and there was no explanation provided for why. And then from our perspective, I'd say the limitations are that there are very few patients with dementia. There's no mention of delirium prevalence at all in this trial. There's no mention of decubitus ulcers. These are all things that are important to us, and I'd say are important to patients. And then just a point that bugged me is that frailty was in the acronym of this trial, but they didn't measure frailty at baseline or in the outcomes assessment. Okay, so just quickly, what could there be a reason for why this trial is different than the ICU literature? And I would just say that it's possibly related to the disease, but actually I think it might be more related to the nutritional intervention. So yes, patients in the ICU are more sick, and yes, that might mean that there's some difference in this autophagy or insulin resistance. But I wonder if it actually has something to do with the types of interventions that were given, and perhaps it speaks to the fact that we haven't evolved to receive continuous nutrition all the time, enteral feeding. That's not really something that's as natural, perhaps, as getting oral supplements and normal food 3 times a day. Okay, so back to our case. So Mrs. S, she's 87, she's frail, she has pneumonia and functional decline. So the question was, would she benefit from oral nutritional supplements, protein fortification, or enteral feeding? And I would say that this study supports systematically screening these patients and giving oral supplements, but doesn't, I would say the support for enteral or parenteral feeding in these populations is unknown, because there were very few patients in the trial that received this. So these are my references. Thank you. I'll take questions now, and there's also just some food for thought and questions to think about here.
Thank you very much, Christina, for that lovely presentation.